Welcome. My name is Gil Ramirez. For those of you who do not know me, I've been asked to kind of kick off this grand opening event of the new School of Public Health with this new speaker series, hereby known as the Public Health Dialogues. And we welcome you today. It appears it will be a very interesting discussion, but before we go there, I want to do something special. We want to, things like speaker series, they just don't happen. And our successes today just don't materialize out of thin air. They're built usually on the efforts of others who have come before. And so I'd like to recognize someone very special to the school, Rachel Abraham, Dr. Abraham, and ask her to come forward. Rachel has a long history with the public health at West Virginia University and West Virginia. I've only known her for 2 years, but one of the first events when I arrived 2 years ago was coming to something known as Public Health Grand Rounds, which was the precursor to Public Health Dialogues. Rachel did a selfless effort for 10 years, not only starting the Public Health Grand Rounds, but carrying it through. And I think none of us really recognize how much work is involved until we started doing it for ourselves without Rachel. But it was a fantastic Public Health Grand Rounds. She's known throughout West Virginia. She's known throughout the world, actually, in terms of these types of series, the offering of continuing education credit, and actually was very instrumental in my renewing my CPH exam CE at the last minute, trying to capture all the CEs that I needed. So we want to thank Rachel for all of her hard effort these past 10 years, and we do certainly stand on her shoulders as we move forward. And we have a couple things for you, Rachel. We actually have a plaque that recognizes our appreciation for Rachel for her leadership and dedication for 10 years of work. But this will probably be behind her on her wall, and she'll never see it. So we also have for her a nice paperweight she can always look at and see in front of her that we also appreciate her 10 years of effort. So thank you very much. And now I've done my job, I'll turn it over to someone who can do a much better job, Dr. Lauri Andress.
Thank you, Dr. Ramirez. I have somebody's cell phone up here. Oh, okay. All right, great. Welcome. Thank you for coming today. We have a few housekeeping items to get through. We're deeply grateful to Rachel for starting our first Public Health School Speaker Series. Today we're starting Public Health Dialogues, and I wanted to talk a little bit about the genesis for this speaker series. I want to recognize a few people who helped to get this off the ground, and it reminds me of my favorite saying, there is no I in teen. So it comes from a really corny movie, but I remember that, there is no I in teen. So I wanted to recognize Kathy Hess, if she's here, and then raise your hand, Kathy, or can you come down, Kathy? I got little gifts for everybody, so this is for Kathy. And then Teresa Ness as well, and then Crystal Rhodes. So I want to make sure they get a hand because couldn't have done this without them. Thank you. Thank you very much. I really appreciated it. Thank you. Now, when we got ready to start the new speaker series, it was about 6 months ago. And if you guys will bear with me, I know this is trivia to everybody else. We talked to people around the school, and so there were some people who really gave us good ideas on how to get this deal kicked off. And so I wanted to recognize Keith Zulik, Gene Siebert, Janet Hunt, Jeff Coben, Matt Gurka, Gil Ramirez, who was just up here, and thank them for helping us work through how to create this speaker series. A few other facts. We are looking for nominations for speakers. One of the things that we wanted to do with the new speaker series was to open up the process. So you can get that information to us in an email, a smoke signal. We actually have a proposal if you want to fill out that proposal. But we're interested in other ideas for speakers and topics. And so some of that information is rolling past you on the screen up here, but we'll be sending out another announcement. You don't have to be a special group to participate in this. You don't have to have an organization. But if you have an idea for a speaker and a topic, get it to us, and we will work with you to see how we can make that happen. You have index cards. I'm hoping that everybody has an index card. We're going to try something a little bit different today. As we go through the presentation, if you have a question, please write it on that card, and then hold your hand up with the card, and someone will come and pick it up and bring it up to the front. And so that's how we're going to do the Q&A session today. If you try to fit your questions on that one card, if you need another card, just raise your hand, and the two students that were passing them out will bring you more cards. A little bit about what's going to happen today. This is a panel discussion. This is the first time that we've had a panel discussion for the Public Health Speaker Series, and so we will be using that format today. When we created this speaker series, one of the things that we wanted to do was take on different ideas and topics and different frameworks for public health than we normally see here in the School of Public Health. Things that had not been spoken of here at the School of Public Health. And the idea is kind of like a commercial I saw on TV this morning. I was really surprised to see this. And it was a CVS commercial. And everybody knows that CVS just eliminated selling tobacco in their stores, right? So they were congratulating themselves on that move. And at the end of the commercial, they said, "Health is everything." And I thought, okay, the irony of that statement coming from CVS. So I think they were trying to say that health is very important. But really, when we think about health as everything, that is where we're trying to go with the speaker series this year for 2014 and 2015. And the main point that we want to get across is that health is indeed what we do within our four walls, but also there are other factors outside of these four walls that are equally as important. And so what we're doing with our 2014-2015 speaker series is investigating these other factors that impact health, the social determinants of health. And so if you're interested in what you hear today, we will be bringing other speakers in 2015 and the rest of 2014 that focus on those ideas. So without further ado, I'm going to introduce our speakers today and get us started. We are missing one person, and I am looking for Mr. Hamby. Oh, there you are. Okay. Nice to see you. Thanks for making it. Okay, so we do have three speakers on our panel today, and we're going to start off with Dr. Stephen Woolf from Virginia Commonwealth University. Most of you have that card in the front of you. It describes their background, so I'm not going to read from that card, mostly because I don't have one. If I had it, I probably would read from it. But at any rate, Dr. Stephen Woolf will start off with a PowerPoint presentation. He's going to speak for about 20 minutes. And then Ted Boettner from Charleston, the West Virginia Center on Budget and Policy, will move to the table, and Mr. Hamby will also move to the table. And Chris Hamby is our Pulitzer Prize winning journalist who did a series on black lung and is now with BuzzFeed. So those will be the folks on the panel. And then at that point, I will ask them a series of questions. They will engage in a discussion, and then we'll open up the floor for your questions, which you will write on your note cards. Okay, so let's give Dr. Woolf a hand.
Thank you. And Crystal, I advanced the slides with this here? Okay, great. Well, welcome everybody. Let me warn you that I'm going to be racing through 43 slides in 20 minutes, so it's all going to fly past you pretty quickly. But if you have questions, do write them down on the card, and hopefully during the discussion period we can get to this. Let's begin with something you're probably already familiar with, which is how we spend a lot of money in the United States on healthcare. This is a chart showing the rate of spending on healthcare per capita for the United States, which is the line at the top of the graph, and then the others are for other high-income countries. And so what you can clearly see is that we spend a lot more on healthcare than people do in other countries. And the assumption is that we are healthier as a result of that. How many of you think that's true? Raise your hand. Okay, so you're all on the same page here. I had the, I mean, I'm sure it's true on this campus as it's true at my university. A lot of resources and attention go toward healthcare. There's a perception, and it's probably true, that in the United States we have some of the best technology and doctors in the world. But that doesn't mean that our health care that is received by most of our patients is actually the best in the world. And definitely it's not true that our health is the best in the world. This is a complicated diagram, and we don't have time to actually go through it. The one thing I want to point out to you, though, is this is where the health system fits. This is the World Health Organization's model for the factors that influence health. And just like Lauri said, the CVS tagline is probably true. Health over here is impacted by a lot of factors. Health is everything, right? But the important thing is that we're pouring $2-point-something trillion a year into this box right here, healthcare delivery, even though these other factors not only influence health, but probably influence health more than does healthcare. So I'm not sure what I'm supposed to be aiming this at to make it go. Is it this way here? Ah, there we go. Oh, I just shut off the whole thing.
You're running early, so don't worry.
Okay. So while Crystal's saving me here, I had the opportunity to chair a panel, a National Research Council panel, is sponsored by the National Research Council and the Institute of Medicine, that compared the health of the United States with 16 peer countries. This is actually a picture of the report. You can download it for free if you want to. It's 400 plus pages, but there is an executive summary. But anyway, this report exhaustively compared the health of the United States with these other countries. And what we found, as shown in the title, that Americans have shorter lives and poorer health than people in these other countries. This is showing life expectancy at birth starting in the 1980s and going to the present time. And just to orient you to what you're seeing, the red dot here is the United States. These gray dots are the comparison countries. So you can see back in 1980, we were sort of in the middle, and then over time we've dropped to the bottom. Same for females. But here's, oops, went too fast there. There we go. Here's a chart showing the probability of surviving to age 50. Here's males. As you can see, again, over time, the probability of surviving to age 50 has dropped to the bottom of the pack for the United States. But look at females, completely off the marks here. In other words, the probability of a woman surviving to age 50 is lowest if it's an American woman. And this pattern is not a statistical fluke. You can see over the course of 2 decades, it's getting progressively worse. We don't have time to go through the details here, but just to show you, the red bar is the United States, the gray bars are other countries. Second highest rate from non-communicable diseases, that means chronic diseases like diabetes and heart disease. Fourth highest rate from communicable or infectious diseases. Second highest rate of mortality from injuries. Our heavy spending on healthcare is not working out in terms of our actual health. That's the point I want to make to you. So why? Why is it like this? Much of our analysis, much of that 400 pages goes into that question to try to understand, well, what is the reason why Americans are so much sicker than people in other countries? This is a diagram showing the organization of our analysis, but it's relevant to what we're going to be talking about in terms of here in West Virginia. What are the things that influence our health? Whether it's the United States, a state like West Virginia, your neighborhood, your community. Well, some of it is health care, and health systems here refers to not just medical care, but also nursing care and public health systems and so forth. All of that's obviously important, but a huge factor is individual behaviors. So whether we smoke, whether we're physically active, what we eat, so-called injurious behaviors, which are things like using your seatbelt or not speeding when you're driving and so forth. A whole influence that I'm going to talk about in some detail, social and economic factors, the physical and social environment in which we live, and then affecting all of this are policies and social values, decisions that our leaders make, that voters make, that politicians make, and so forth, that employers make, shape all of this. So that's what we analyze to try to understand why the health of the United States is worse than in other countries. So when you look at how states are doing, there's a report called America's Health Rankings. I don't know how many of you are familiar with it, but every year it comes out around November or so, Thanksgiving time. It's sponsored by the APHA, the American Public Health Association, and some other groups. And every year ranks the health of states. And it's blurry on this, I apologize, but West Virginia is down there, I think. Here's an interesting diagram that I was able to access on the report showing the ranking for West Virginia going back to 1990. And you, again, I apologize for the quality of the image, but basically somewhere between 45 and 50 has been pretty much a consistent pattern, along with several other states that travel in the same pack, where there's been a consistent problem in terms of health disadvantage. And when you look at patterns like that, whether it's a state that's struggling or neighborhoods like the one that my university is in that is consistently having health problems and so forth, we have to think about the various factors that shape health. How many of you have learned about the socio-ecological model? A few hands. So for those of you who don't, it's a recognition that our health is influenced by the conditions in our home, whether we've received a decent education, what kind of income we've received, but also the conditions in our social environment, our physical environment, and so forth. Each of these index cards, so to speak, are various factors that influence health. Much of what you will learn about or hear about on campus at an academic medical center is very focused on this world here of genetics, cellular pathology. I'm a physician myself, so I come from that world and understand that that's a big focus of what we do in clinical medicine. But frankly, health is influenced far more by these other factors. So there's another initiative called the County Health Rankings. I don't know how many of you have heard of this? A few hands. So the County Health Rankings are put out every year. It's actually led by a group at the University of Wisconsin, funded by the Robert Wood Johnson Foundation, and you can look up any county in the country and see how it ranks in its state. So I did this for West Virginia, and one of those maps up there are the health rankings, and one of those maps up there are the determinants of health, those index cards that I showed you that influence health. You can guess which one is the actual health outcomes, but the important point here is there's a tremendous amount of overlap here. As an outsider, I just look at this map and I see, and this is true around the country, a synergy between the factors that influence health and the health outcomes. How many think the health map is on the left? How many think it's on the right? There's like no voters. You're all abstaining. The health map is on the left, just so you know, and the determinants of health are on the right. And the counties that rank the poorest tend to be down in this area over here. And McDowell County, one that I want to focus on for a second, is of course here. But what the important point here is that the factors that are driving this are not necessarily restricted to whether they have a fancy coronary care unit in the local hospital. Much of this has to do with the socioeconomic conditions in those counties and the neighborhood and community conditions there that are driving those health outcomes. At the center that I direct, the Center on Society and Health, which you may have noticed that logo at the bottom of the slides, at my university, we have been producing maps like these around the country, which show differences in life expectancy across very small distances. It's true, you know, in every place here too as well. But shown here are some examples. On the right is New Orleans, the left is Washington, D.C., where you can see just across a few exits on the interstate a big difference in life expectancy. When we think about what's driving differences like this, we recognize that the change points, the opportunities to make a difference and address these disparities in health come from decisions that actually spill out well beyond what we would typically call health care policy. So all the debates about Obamacare and how much spending there is on health care and insurance redesign and physician reimbursement and all of that has really a marginal impact on health outcomes. It's decisions in these other policy areas that actually can make a huge difference. And that's led to this health in all policies movement, a recognition that in policy areas across the board, government and private sector are important in shaping health outcomes. So it's not just, when I trained in medical school, I thought of everything in terms of what's happening in the clinic and when you see patients at the bedside in the hospital. But then they go home, and it's in that environment where their health is actually influenced and where much of the opportunity for change occurs. So I want to focus on a couple of these social determinants that I think are extremely important. One is education and the other is income. So to start with education, and by education I'm referring to the full spectrum, early childhood education, which by most experts is probably the most important area of education we could invest in, but also K through 12, college, and even graduate school, which are becoming more and more difficult to obtain for low-income Americans, to emphasize that these are huge factors affecting our health. People don't appreciate it. For example, this slide here shows the probability of death, and on the x-axis there are the number of years of schooling you get. And you see a pretty obvious pattern. The more education you have, the less likely you are to die. There's a clear gradient in life expectancy, and in terms of diseases that are important concerns for health. This is self-reported health, how often people say their health is fair or poor. Again, you see a clear gradient. Bachelor's degree or higher, only 6% of people saying so. But if you haven't got a high school diploma, 27%. So when you look at that, if you're a young person trying to decide about what to do with your education, there's a particular message there about what's going to improve your health. But also think about this if you're the CEO of a company, you're an employer, and you're really losing your shirt on healthcare expenses. What's this telling you in terms of the importance of education in reducing your outlay on healthcare costs for your workers? There's a huge implication here, and that's why a lot of companies now are investing in, I went too far here, I'm trying to back up. Yeah, I didn't mean to do that. Okay, this is the prevalence of diseases, meaning how common these diseases are. You don't have time to look at all the numbers in this chart, but let me just tell you that the left-hand column is less than a high school diploma, the right-hand column is a bachelor's degree, and for every one of these diseases, you can see the rates drop significantly. So whether you're thinking of this in terms of public health, whether you're thinking of this in terms of healthcare costs, whether you're thinking of this as workforce productivity, education is a big deal. The risk of dying, I mentioned this in an interview a few minutes ago, the risk of dying from diabetes, all right, is a disease that's getting more and more common and that we're all concerned about, and employers are worried about because it costs so much. The risk of dying from diabetes among middle-aged adults is 3 times higher if you haven't graduated from high school than if you've had some college education. That threefold difference is something we cannot accomplish at the bedside in a clinical setting. There's nothing I can prescribe as a physician that's going to change diabetes outcomes that dramatically. This is a study we did a few years ago trying to put this in perspective. How many lives are saved by biomedical advances versus how many lives would be saved if we got everybody the death rate that exists for people with a college education. The tall bars in the back are how many lives would be saved by improving education. The short stubby bars in the front are how many lives are saved by biomedical advances. It's a ratio of 7 to 1. And yet we put all of our money in the biomedical advances and generally cut funding for education. So to give this a little local context, I used a tool that we have developed at our center called the County Health Calculator, where you can type in any county you want in the country and look at the influence of education and income on health. And I chose McDowell County because it, at least in terms of the education variable, has the worst level of college attainment in the state And so what it basically shows is that 22% of adults in McDowell County have a college education, whereas the best is in Jefferson County. And it's a dynamic tool which you can use out online if you just Google County Health Calculator. But these screenshots show you what happens. If you increase the slider, if you just take that slider, which is at 22%, and move it to the state average, which is 41%, what you can see over here in these 3 bars at the bottom is what happens to the death rate, the number of people with diabetes, and diabetes costs. You start seeing it falling. Or if you want to just read this text version, you can see the implications of doing this, where you have 19% more of the population attending some college and so forth. In that county, 33 lives saved each year, 391 cases of diabetes, $2.4 million in costs for caring for diabetes as a result of the improved education. If you bump the rate up to what it is in Jefferson County, you can see the numbers increase even more dramatically. There's very little that the Obamacare or other health reform people are looking at in terms of cost-saving strategies that can reduce the cost of disease by that much. So while they're wringing their hands trying to figure out how to control the rising costs of health care, there's a pretty obvious solution by dealing with these basic social issues, which are also good for the economy, because it's not only important for health care, it's important for education. This is a study we did in, I guess I'm shifting gears now from education to income because we're short on time. Study we did in Virginia looking at how many deaths are averted or could be averted by improving the income, and we found that 25% of deaths in Virginia wouldn't have happened between 1990 and 2006 if everybody had the income of people in Northern Virginia. So this issue is obviously very important here in West Virginia because of the large proportion of the population dealing with poverty. The map on the right shows the various poverty rates across the state. And again, you see that cluster in the area I mentioned earlier. The bar chart on the left is showing the trends in the poverty rate over time in West Virginia going back to 1969. And for comparison, I put in the U.S. poverty rate over that same time period. So that you can see that this high poverty rate is a long-standing issue in the state. I'm old enough to remember this period. I don't know how many of you in the audience were around then, probably not many. But I remember when Kennedy came to McDowell County, and what's striking about this all these years later is that that was, at that point, the place to go for a press event to address the significant poverty problem. Shown here are his actual speech at the time, where he was talking about how that area had once been an area of economic boom back in the late 19th century and early 1900s, but now was struggling with severe poverty and food insecurity, hunger, and so forth, and was recognized at that point that major changes were needed, and this gave rise to the war on poverty. Jump ahead 50 years. The New York Times had an article last March by Lauri where she contrasted McDowell County with my county. I live in Fairfax County, Virginia, outside of Washington, D.C., which has the highest income in the United States. And she was pointing out that across this relatively short distance between this most affluent county and McDowell County, there are not only huge differences in living conditions, but also in life expectancy. So this is a chart from that article where you can see Fairfax County shown over here, McDowell County over here, and this disparity in life expectancy was true both at the time of the article, but also going back in time to 1990. So it has huge implications in terms of how long we live. This is a quote from the article. Residents of Fairfax County, men have an average life expectancy of 82 years, women 85, something like Sweden's, whereas in McDowell County, 64 and 73, more like Iraq. Meanwhile, you have these politicians who are trying to figure out what to do about the costs of health care and having all these debates about it, and often cutting spending on policies that would help with education, and that would improve wages and earnings because of the cost of health care in order to balance the budget. It's sort of an ironic twist of events. And yet, if you look at the math and think about what diseases are driving those expenses, it seems pretty obvious. If you look here, this is showing disease rates by income, that if we were to improve the income of the middle class, take more people out of poverty, we would see striking decreases in disease rates and therefore be spending out far less on health care. It's true for disease burden. This is the number of people reporting fair or poor health. The environment in which we live, people who live in low-income neighborhoods because they can't afford to move to healthier neighborhoods are exposed to a variety of environmental factors that increase their unhealthy living, whereas those who can afford to live in the neighborhood on the left are obviously going to experience more healthful conditions. Mental health is a big concern, both in terms of healthcare system burden and other social ills. And here again, you see this clear income gradient, where the people who are doing better financially are going to be in better mental health as well as physical health. We are very conscious in our country now about the growing income inequality, where only the top 1% have seen their income grow over the last decade or so, and the middle class is dropping in terms of real median income. Those trends have very big implications in terms of public health and healthcare costs. This is a chart showing that in 42% of U.S. counties in the United States, the death rate for women has increased since the 1990s, whereas it has decreased in most of the world, and it's decreased for men. For women, it's increasing. Why? Why is the health of women getting worse? We think a lot of it has to do with these socioeconomic conditions that we're talking about. We can talk more about that during the discussion period. This is a slide trying to project that cost curve for healthcare, and how do we get control over the cost of healthcare. And I only have enough time to tell you that the one strategy that seems to actually bend the cost curve in the direction we want is the one that deals with these root causes, these social and behavioral determinants of health. The other strategies are looking only at healthcare system redesign. Strategies that are now focusing on dealing with these social problems are finding that they are far more effective in controlling healthcare costs than other interventions. This example here is helping people with unstable housing reduced ER utilization by 50%. The healthcare community is beginning to understand that if it really wants to change and move the needle on overutilization of healthcare and costs, it has to deal with these social and economic problems. So in the interest of time, I'll leave it there. The caption says, my question is, are we making an impact? And it's a joke, but basically the point is, if I go back to this slide here and you see this trend that I told you about, where the U.S. is losing ground compared to the other countries, we're going to keep losing ground unless we make a big change. The evidence here indicates that we're going to continue to fall behind other countries and live shorter lives and poor health unless we deal with these upstream factors that influence health. This is my contact information, and sorry I went over, Tim.
Thank you, Stephen. I'd like to ask the other panelists to come up to the table, Stephen, Chris, and Ted. And while they're on their way up here, if you have written any questions on your card, can you hold your card up so somebody can pick it up, please? And as you write questions, hold your card up. I'm also a salesman nowadays. We have these public health Grand Rounds cups that we'll be giving away at the end of this session. If you're around, it's celebrating 10 years of our speaker event as well as the new speaker event. So hang around for the ending. All right, so we're going to start the questioning of the panelists. And I think that what I want to do is start with a general question both for Ted and Chris. And I'm going to ask Ted to go first. And thinking about the social determinants of health framework that we have heard Dr. Woolf talk about, can you describe what you do in your organization? Tell us a little bit about your organization and how you would use that social determinants of health framework to further the objectives of your organization.
Yeah, thank you very much. First of all, it's a real honor to be here. I really appreciate being up at Morgantown once again. And I'm with the West Virginia Center on Budget and Policy, and we're a nonprofit, nonpartisan 501c3 research center located in Charleston, West Virginia. We work on family economic security, tax and budget issues, and economic development. And the key, all of these are related. They all are one. I think I'm going to steal a line from Stephen Woolf about that, economic policy is health policy. And I think that is sort of like an axiom we can take away from that presentation there. And what we try to do at the center is to work on policies to improve the lives of low and moderate West Virginians. And we do this in a whole array of capacities, and there's so many things that we can do in West Virginia to address these issues. It's just a matter of will, involvement, and seeing this as something that people care about. And I think, as we talked about, dealing up here at the medical school, there's limits to what we can do inside these buildings. We have to get out in our communities and be part of that conversation. And there's several initiatives that we're working on to do that. But first, just to look at West Virginia uniquely, how are we different than some of these other states with these other problems? Most states that have high poverty also have these poor health outcomes. And I think West Virginia does have some unique features that lend itself to some of these poorer outcomes. We've been a mining state since the very beginning. And this has led to a very boom and bust period in our economy with feast or famine, and it's left a lot of communities unable to be developed. One Appalachian historian always says, we've had economic growth in West Virginia, but we haven't had development. And I think that's a really important thing to understand and get behind. But also, we're a very rugged state. We're not close to a lot of industrial centers. We've also, the natural resource extraction in the state and shared prosperity exactly haven't gone hand in hand in West Virginia and other parts of the Appalachian region. Those are the kind of things that we have to deal with. So we know that the past is built into the present. So when we're trying to deal with these issues, we also have to look to the past to figure out what policies that we can do that. And one thing that I've found being sort of a policy wonk in West Virginia is that I don't have all the answers, and that these things have to come from the community, from the bottom up, and people have to be engaged. I'm a parent. I just had a son 2 weeks ago, so I'm lucky to be here. But as somebody who likes to do research and analysis, I have to be involved. Everybody in this room needs to be involved in their communities and what happens. And that would be the way that we will really make a difference in changing these indicators. So that's sort of what we do. One issue that we've worked on recently is home visiting. One thing that happens to younger children is toxic stress, and having a household when you're living in extreme poverty or chronic poverty, or even at 150% of the poverty level, these can lead to really poor outcomes later on in life. Increased risk of diabetes, a lot of the health indicators that we were just talking about. So how can we deal with that? One thing we know that really works well is home visiting. And we have a program called Birth to 3 in West Virginia. That's one thing that we have. I've benefited from that. They've come to our house once a month. And I'll tell you, got a pretty good education, but I don't know everything there is about parenting. I don't know the things that I need to do with my own daughter sometimes, but having that help and getting that intervention. And when we're talking about half of the kids in West Virginia live below a living wage household. Half. So half the kids have parents who don't make enough to get by. So one thing that we can do policy-wise is expand a program like home visiting that will help give parents the tools that they need and the information they need to help their children. And this is one of the critical ways that I think we can address these problems, and it's early on. People used to always joke around and say, vote early and vote often. I think you invest early and invest often in these kids and these communities, and we will change those things, but it's going to take all of us to come together and to be feeling like this is part of what we do as parents, is get involved in the political process and also within our communities to legislators understand exactly what's important to us.
All right, I want to move on to Chris Hamby. And as I said earlier, Chris is currently an investigative reporter at BuzzFeed. Prior to that, he was at the Center for Public Integrity, and he did an investigative piece on black lung in West Virginia. And I would like for him to talk about the work that he did and what he found, and then also within the framework of the social determinants of health, what kinds of changes would we need to see in the state of West Virginia around the mining industry to kind of deal with black lung, head off the disease, and cut the rates of black lung in West Virginia, from your perspective?
Well, thank you, and thanks for having me, and it's great to be on the stage with these guys. I have no particular training in public health. I talk to people like this who are a lot smarter than I am and help me understand this stuff. And but over the past few years, black lung has actually become sort of an obsession of mine. And it started a few years ago when a report came out from the governor's task force who he'd appointed to look into the Upper Big Branch mine disaster, where 29 men were killed. And they did autopsies of, they were able to do autopsies and look at the lungs of 24 of those men, and 17 of them had signs of black lung. I look at that, and I think probably like a lot of people, although you guys probably know more than I do and weren't surprised by this, but that's a pretty shocking number. And I thought black lung was something that was a thing of a bygone era, that would not be afflicting miners in West Virginia today. I came to find out that was not the case, and actually that the National Institute for Occupational Safety and Health, based right here, is doing some great work on something that frankly should not be happening, which is a resurgence of the disease since the late 90s. And there was landmark legislation in 1969 that was supposed to virtually eradicate the disease. That seemed to be working until the late 1990s. However, since then, we've seen an increase in both the prevalence of the disease and also a particularly disturbing trend of younger guys getting a faster, progressive, nastier form of the disease. So that was pretty shocking to me. And I did a lot of reporting in the coal fields on that, focused pretty much in southern West Virginia. We're seeing these effects the most severe in this area of Central Appalachia and southern West Virginia, eastern Kentucky, and southwestern Virginia. And that was very reflective of some of those health outcomes that Stephen showed on the map earlier. Now, while I was doing that, I also came across a lot of complaints about the benefits system, and that's what the most recent series that I did was primarily about. But, so since we're looking to go upstream here today, I think looking at the causes of why black lung still exists and why it's getting worse. And I did try to determine that, and I don't know that we have any definitive answers, but so black lung is something that we've known since the mid-1800s, really, that this is a disease that afflicts coal miners. People were documenting men spitting up a black sputum, and they were documenting all these breathing impairments, and it's been called miner's asthma and all sorts of other things. And there was a real resistance to any sort of recognition of the disease, which inhibited any sort of real policy response to it. It was finally after the Farmington disaster in 1968, when 78 miners were killed in an explosion, the media descended on West Virginia, and then that advocate sort of seized on that opportunity to say, not only do we have people blowing up and getting killed in rock falls, but we also have miners dying by the thousands of this entirely preventable disease that we've been documenting for a while, but we have not really been doing much from a public policy standpoint. And so in 1969, they set out dust standards and they set out regulations implementing the legislation that Congress passed, and that was, as I said, supposed to virtually eradicate the disease. Now, that's where a lot of the history on black lung has stopped in terms of, I mean, there have been some really great books. Alan Derrickson at Penn State wrote a terrific book called Black Lung, Anatomy of a Public Health Disaster, which I think is a pretty accurate term, a pretty accurate description of how we've dealt with the disease over the last 150 years or so as a country. But what interests me is a lot of stuff that really matters is once we've laid out these grand principles, we've passed a law and said, we're going to eradicate this disease and we're going to compensate the men who get it. The rubber hits the road when that becomes a regulatory policy. So that's where, that's where it really matters, where you have to nail things down and get them right from a policy standpoint. And I think a lot of what we're seeing today is a result of weaknesses in the implementation of the 1969 law. So it's not just enough to pass the law and declare victory. You have to establish the right ground, the right framework, and then you have to constantly monitor and enforce it. And that's what's really happened, and in a couple of ways that it's kind of, I think, allowed this to happen. One, frankly, rampant cheating on dust samples in the mines. Mine operators are supposed to take samples, and the Mine Safety Health Administration also has inspectors who come in and sample for dust levels and will cite you if you're above a standard. Frankly, I don't know that I've talked to a miner who hasn't described committing or being party to or witnessing some form of fraud, where they will put the sampler in a lunchbox or they'll hang it in the clean air intake. Anything to avoid getting dust in that sample. And frankly, if you look at the samples, it doesn't make sense. And NIOSH did this, and they looked at the levels that companies were recording, and then they predicted the level of disease that would occur based on that, and it was way off. The disease was much, much higher than what they would have predicted. Well, I think a pretty good explanation for that is that the samples do not reflect reality. And so there's the cheating aspect, and then there's also the loopholes in the policy, which is a really important policy point. When they designed the system, they allowed you to average 5 samples, to sample over only 8 hours, even if the miner works 10, 12, longer than that, which does happen. And you can sample at 50% production, which is generating a lot less dust. And if you do happen to get a sample, all you have to do is, to abate that, is to submit 5 of your own samples that you've taken yourself. So it's the analogy that people use a lot is that a cop gives me a speeding ticket and says, okay, I want you to come back by the same stretch of road for the next 5 days and record how fast you were going. Just tell me, I'll trust you. And if it's below the limit, I'll tear up your ticket. But that's the way this system has been working. So, and then that combined with some sort of modern trends like a lot of the thicker seams of coal have been mined out, so we're cutting a lot more rock, which is more toxic to the lungs. Guys are working longer hours. There's more advanced machinery, like a long wall machine. If you've ever seen one of those, it is a scary behemoth, but it gets the job done. And I mean, all of this sort of combines to undercut a well-intentioned policy that was really full of loopholes. But I will say that the Mine Safety and Health Administration did just finalize a rule that is now taking effect, the first part took effect in August, that addresses a lot of these loopholes. So, but from a policy standpoint, I mean, it's important. I can't stress how much of our lives are really dictated by regulatory policy that does not get near the attention that legislation or big pronouncements do. But it's really those little details like this that make all the difference.
Thanks, Chris. Ted, I want to ask you to kind of react to what Chris just described and think about employment trends in the state of West Virginia, where most of the jobs are, and what's being done over the last 5 to 8 years with regard to employment and jobs in the state of West Virginia.
Okay. First of all, Chris, I just want to say that was amazing work that you did, just amazing. We were all talking about it when it came out and everything, so those are things that I know a lot of, like my dad was a lawyer that worked on black lung cases for a long time. But, you know, West Virginia, we put out a report last year, which I always say sort of typifies West Virginia's economy a little bit. It's called Weirton to Walmart. Weirton Steel was our biggest state's employer back in the 70s, and now Walmart is. And back in the 70s, a typical worker at Weird and Steel would make at least $16 an hour in the 1970s. Now, today, fast forward 35 years, somebody at Walmart doesn't even begin to make that type of salary. And that's the kind of shift we've seen in our economy, too. And there has, been a shift towards the service sector, just like around the other parts of the state. But when you had a state like West Virginia, where only 5% of the workforce in the 70s had a college education, and you have such a disaster and a fall in the steel industry like we did, and a collapse in mining too at that period, it really left us in a really tough spot. In the '83 recession, West Virginia was far worse than anything that's happened recently. We had unemployment of over 20%. So after this long period, a lot of people left West Virginia. We have approximately the same population as we did in the 1970s, so we haven't grown too much. So more recently, we've seen a resurgence in shale development that is leading to more employment in this part of the state, but we're also seeing a huge drop in coal employment in the southern part of the state. Boone County, for instance, which was our biggest coal-producing county, has dropped about 2,000 jobs, but they're still about where they were in 2000. But we still rank in the very, very bottom in terms of the share of the workforce that has a post-secondary degree. And that's largely tied up with the nature of concentrating on the mining industry. When you do that, there's not a lot of incentive to get that post-secondary degree, and it can sort of crowd out other businesses that are looking for a differently trained workforce. So we've had to sort of live in that environment in West Virginia over the last couple of decades, and it takes a lot to get out of there. And we have to continue to do that to move forward. But the biggest factor, when I look at the social determinants of health, all of these things, just one data statistic always stands out in my mind: real wages. The wages of the typical worker in the middle of the wage spectrum have declined by almost $1 since the late 70s. I mean, that means you have more people in the workforce. That's why females are more entering the workforce for other reasons too. But people are working harder, more hours, receiving less, can't afford childcare. Back comes this toxic stress and all of these things that can happen to kids early on, and the parent and that structure is broken down. We've also seen a huge drop in social capital. People used to belong to unions, people went to churches more, people were more involved in civic participations. In some ways, it was easier to be poor in the 60s. A lot of people didn't know they were poor, but it was easier. But now we've seen a breakdown in the community as well. And one exciting thing that we are trying to do, that we're a part of, is the Our Children, Our Future campaign, which is made up of over 1,800 organizations and individuals around the state that want to end child poverty in the state. And we are organizing all across the state. We're having our policy forum next week at the Capitol. We should have about 400 to 500 people there. And the biggest thing I would ask is that people get involved in those issues, because we have to make our communities stronger and stronger to enact the policies that we do. One thing that we did last year that was really incredible was we raised the minimum wage, and that was largely through this campaign. We raised the minimum wage from $7.25 to $8.75, which might not mean to a lot of people in this room, but a lot of people are paying their bills based on that. So we're talking about increasing wages of $100 million next year and impacting 100,000 people in the state that are struggling to make ends meet. That makes it much easier and more likely that you won't have these adverse things that happen back in people's homes, because those economic stresses and losing your job in the coal mining industry or whatever can really lead to these poor outcomes, and that vicious cycle of not improving health outcomes and economic outcomes later on down the road.
So, Stephen, Ted brought up an interesting idea, which is this notion of chronic stress and how it plays a role in the social determinants of health. So we know that these factors like affordable housing, transportation, wages, make a difference in health. And we can see that in terms of absolute wealth and absolute impacts. But there's also this notion of relative wealth and how the social determinants of health get under the skin to impact health. Can you talk a little bit about those theories, like the allostatic load? And
yeah, when I started out in my career years ago, we just knew there was this correlation. And what modern science has now helped us understand is, as you put it, what's going on under the skin, the actual biology of how a young child's exposure to stress causes them to develop adult diseases 10, 20, 30, 40 years later. So for example, we know early childhood, age 0 to 3, is a time of rapid development of the brain and nervous system. And it turns out that children who are exposed to stressful environmental conditions like poverty and the other problems that we've just discussed have what are called neuroplastic changes in the development of their brains that not only affect their behavior, for example, their tendency later on in life to need tobacco, drugs, or other kinds of dependencies to cope with stress, but also change them physiologically. The immune system, the endocrine system, the actual hormonal system that connects the brain to the adrenal glands and other organs in the body, are adversely impacted by this stress and cause end organ damage that has its early stages in childhood, but set the body on a course for developing diabetes, heart disease, atherosclerotic changes later in life, so that studies have shown that kids exposed to these ACEs, adverse childhood events, are multiple times higher to have adult diseases later in life. So surveys that have been done of middle-aged adults, these surveys have been going on since the late 1990s, show rates of diabetes, emphysema, and other conditions that are many times higher and correlated in a dose-response relationship with their memories of adverse childhood experiences when they were small children. So we are basically raising a generation of young people that are on a flight path for higher disease rates and higher healthcare costs unless we control those environmental conditions.
Thank you. I have a question for Chris from the audience that I want to share with you, Chris. And the question is the following. In your conversations with minors and their advocates, do you get the sense that they feel like the new MSHA rule went far enough with its new protections, MSHA?
Well, I haven't had a whole lot of conversations with minors specifically about the new regulations. I think from the conversations that I've had with minors and their advocates, they were a little bit surprised. One that, well, first of all, MSHA proposed reducing the standard from 2 milligrams per cubic meter to 1 milligram per cubic meter. They ended up issuing sort of a compromise of 1.5. I think that sort of surprised a number of people, and some people were disappointed. Some people viewed that as sort of not a big deal. That I think people are generally happy that the loopholes are being closed for the most part. But again, there are a lot of miners you talk to who feel like black lung is an inevitable part of coal mining and that it cannot be eradicated. And it's just, I think a lot of people would tell you it's not true, or their position is not necessarily that it can't be eradicated, but that you cannot operate profitably and control dust to the level that it would eradicate the disease. And I think that's not true, because we've known for a long time what measures can prevent this, which is maintaining water sprays, following your ventilation plan. I mean, as a last resort, wearing a respirator. These things are not that complicated, but it's a matter of actually doing it and forcing people to do it. And I think that a lot of miners don't have faith that that it will actually be enforced. And I think the feeling is that maybe the standard was not so much the problem as the fact that there's just been no real enforcement of it. And a lot of miners just don't feel like there can be any real enforcement of it. So that's the general take that I've heard. But I mean, people are certainly hopeful, and this is a major step in the right direction from a policy standpoint in a lot of people's views. Now, they have been sued by the National Mining Association and Murray Energy and others, but so they would not agree with that statement. But I think a lot of people view it as probably the best that we could feasibly have done within the current climate.
Thank you, Chris. There's been a lot of research around brain science and early childhood education and development policies, and the connection between how we fund our early childhood education and development system, improvements in the brain development of children, and how that impacts health outcomes in the long run. So I wanted to ask Dr. Woolf, first of all, to talk about the kind of education that he means when he mentions education in comparison to the way that we sometimes think about education in public health as health education, so make that distinction. And then someone asked the question, with the current Congress being extremely unproductive, how do you think we can move forward as a country to address the issue of education and poor health? So if you'll first talk about what kind of education you're talking about, and then try to address it.
Well, I mean, the health education that people typically think about when you discuss the connections between education and health is still important, and that is to teach young people and adults that smoking is bad for your health, and how to eat a healthy diet, and all the other aspects of health promotion that are important to convey. But the kind of education that I'm talking about is educational attainment, actually graduating from high school, getting a college education. We live in a knowledge economy, and as Ted has pointed out, in a state like West Virginia, that vulnerability that exists to these fallout in the mining economy exists because there is not educational attainment that allows people to switch careers into other areas. And in today's world, a bachelor's degree is at a minimum, if not a graduate school degree, is important to get the higher earning jobs. And yet most Americans, it's probably true in West Virginia too, are being priced out of a college education because of the tuition and the loans and so forth that are just unbearable. So we are facing a widening disparity in our country between the health of people who have an education and the rest of Americans who aren't getting that education. And so that's the kind of education that we're talking about, the kind of education that allows you to be successful. But those early childhood conditions that we were talking about is what sets young people on a path for success, both in school and in their health. Exposure to those adverse childhood conditions early in life are part of the reason why teachers and educators feel that kids are failing in school, and also, as I just mentioned earlier, creates a biological stew that adversely impacts their health as well. So part of this correlation that we see between education and health has its roots in those early childhood years. Can't remember your second question.
I think I'm going to switch that second question to Ted and have him localize it and talk about what the West Virginia legislature has done with regard to education funding. I believe that the state has some pretty good early childhood education policies, but what have you seen from the standpoint of your organization in terms of funding for secondary school, higher education, if you have any comments on that?
Yeah, I mean, unfortunately, we've made a pretty brass decision to decrease our amount of aid to higher education. We've cut higher education by about $50 million in our state budget the last 2 years. That's why tuition's going up 8%. And there's some other things that need to be dealt with at the education level in terms of administrative costs and why tuition's rising so fastly. But this is making it much, much harder. The average debt in West Virginia is a little over $35,000, and this plays out in whole different ways of, can I be a school teacher in West Virginia if I have a debt of over $35,000? It makes it hard to make that decision and that career choice. So these things are going to impact us not today, but over the long term as well. Traditionally, West Virginia has done a pretty good job compared to other states in terms of funding higher education, given our fiscal capacity in the state. You know, in terms of K through 12, we make pretty good effort there in terms of our revenue system. There's lots of things we could be doing. One thing we rank very low, about I think 48th in teacher pay. So it makes it very difficult to attract people and to get them to stay here to be teachers. That's one of the things I would heavily invest in. But just recently, the governor has a task force on childhood planning I've been involved with and others have been involved with, and we've actually been partnering with WVU to look at dealing with substance abuse in pregnant women and neonatal absence syndrome, which is a chronic problem, as people know, in West Virginia, and the interventions that we can do in that process, whether it's a different type of drug like Subutex or methadone, and some type of coaching and parenting, if we can reduce those costs in the NICU later on and also help that child right there, right then, we're talking about massive savings down the road just for that intervention. So really turning our focus to early childhood education and intervention programs like Right from the Start, Birth to 3, Drug-Free Moms and Babies program. These types of things I think, have a lot of potential. West Virginia does a pretty good job in terms of 4-year-old pre-K. There's a big push. The President Obama has talked about that in his State of the State. West Virginia has enrollment close to 90%, and we're looking at 100%. In 2015, and that's really good for me because I'm a parent. I have a 2-year-old, and I can't wait not to have to pay $9,000 a year for childcare, so they can go into a school system and be with their peers, and it'll make my life a lot easier, and plus a richer environment for my daughter as well. And we do a really good job with that. What we don't do a really good job with are those early intervention programs, and I think a lot of the work, pioneering work by James Heckman and others, have shown that that is really where you get the bang for the buck. It's really the very early of pregnant women, the first 2 years. And that comes back to these early intervention programs. And the governor's task force recently recommended to expand home visiting and make it universal. It's going to take a heavy lift to do that over a couple of years. It'll probably need about $25 million to do that. And these are the priorities that we make. You know, recently we've cut taxes by close to $500 million over the last year. So we would have about $500 million this year if we didn't cut 2 business taxes, and we got rid of the food tax. You can say whether these are good or bad, but these are public policy priorities. Do we want those lower taxes, or do we want to make these investments early on that have much better payoff, I would argue, and they will increase growth. It will make our state way more attractive for business, and we'll have more tax revenue down the road. But we have to willing to come together as a community to say, no, tax cuts might be good. I might have a little less. I have to pay a little less in state income taxes. But over the long term, that's really going to hurt us if we don't make those investments, especially early on, because there is that consensus. How do you do anything about poverty? It's always like, we can't do anything. Well, let me tell you, the early intervention program, putting a lot of emphasis on that is one of the first places I would go. It's definitely not the answer. There's tons of other answers. But we know that those things have been studied to death, too, and the results look very promising.
I want to switch now and do a little comparative analysis and think about other places. So we know from one of Dr. Woolf's slides that West Virginia consistently has ranked very low in comparison to other states. And so when you rank West Virginia in comparison to Mississippi, Alabama, Louisiana, and I think Arkansas, they all kind of group in the same place in terms of rankings. But one of the big questions that we wanted to try to tackle today is what's unique about West Virginia in comparison to those other places that have high rates of poverty and high rates of disease and death. So thinking about West Virginia and a little bit about the mining question. So one of the questions I had here is that what do other countries and communities do in terms of mining practices or utilization of resources, mineral resources, oil and gas resources? What kind of policies do they have in place? And then also, what are the social determinants of health challenges that we're facing in West Virginia in comparison to other countries or other states that consistently rank low as we do here in West Virginia? And I'm going to start with Chris and then go to Stephen and then down the line to Ted.
I think one significant policy difference comparing the U.S. and other countries, the way we compensate people. Now, that sounds like a back end, you're dealing with the problem after it occurred, but in fact, a lot of these policies, so when the law was initially passed in 1969, it was supposed to put, the way it evolved was that mine operators would be on the hook if to pay for benefits, and that should incentivize prevention, which if you have a system that allows them to duck liability after the fact, then you remove that incentive. And it's interesting to compare the way that our benefit system here has evolved versus other countries' compensation schemes and the way other workers' compensation schemes have evolved. In the US, it is designed as very overtly adversarial in the federal Black Lung program. And in other contexts, it is not necessarily adversarial. It's more of a neutral panel trying to fact find about whether someone is entitled to benefits. Now, the way we have the system set up is that you're going to have, and the adversary system is very much an American thing, and it's a lot of times works very nicely, but it tends to be more of a problem when you have one side that has vastly more resources, almost inevitably. I don't think you could come up with any case where a miner will have the same resources available to them that a coal operator will to fight the claim. And so what you end up with is this system that you're allowed to not have any economic consequences on the front end for preventing it, and you're allowed to not bear any of the economic costs on the back end either. Now, some other places have done much better with this. Australia in the mining industry has done a lot better with preventing black lung. Other workers' compensation schemes, I mean, it's very different in Canada or the UK. That sometimes even the back end incentives can drive the front end preventive measures.
Thank you. Dr. Woolf?
So my perspective on answering your question is broader because our analysis that we did in our report that I told you about covered so many diseases. Obesity, diabetes, heart disease, car accidents, and we did not drill down to black lung or specific industrial diseases. But the fascinating thing was that there was a trend across all of these. And that's why I mentioned in my presentation the importance of public policies and social values, because although we could not find a magic bullet, so to speak, that explained why the U.S. has a health disadvantage across all of these different diseases, down at the distal end of what the factors that immediately cause disease, there was a potential explanation in terms of our social values. What makes America different from these other countries about how we go about making choices that might explain why across so many different areas, from heart disease to car accidents, we are doing worse. And that ended us bringing in political scientists. And so when I listened to Chris talk about this particular topic, what I, as a very simplistic non-political scientist, say is it's special interests ruling the day. These loopholes exist and are allowed to be tolerated because it's in the best interest of powerful forces that have an influence on public policy. So in these other countries where politicians are not necessarily as dependent on campaign donations and so forth, where they receive support, where attitudes about social or cultural or ideological issues are very different, such as attitudes about big government or paying more taxes to the government to tolerate programs. We have a Second Amendment in this country that those countries don't have. So attitudes about a lot of these ideological issues end up shaping decisions that downstream result in different conditions in our neighborhoods and economic opportunities.
Nicely put. Ted, again, the question is a comparative analysis. And when you think about West Virginia and the other states that consistently rank lower in health outcomes and other kinds of social outcomes, what do you see about West Virginia and the social determinants of health that make us different?
I think there are some real positive things too in West Virginia that we sort of neglect to talk about. Like, I love to hunt and fish. Like, I love it. I love to go backpacking. And West Virginia's got great natural assets. But on the other end, there's lots of mining practices and lots of problems, environmental degradation and things. On the opposite end, there's sort of like these contradictions that are holding us there. And, you know, one thing to address, too, is like it's the big question of West Virginia that one of the West Virginia's historians, John Alexander Williams, asked is, why is the state so rich in natural resources, so poor? And I think that's the critical question that's never been fully answered, and I think it'd be hard to answer it. But other areas, especially like Norway and parts of Canada like Alberta, and even parts of Minnesota, have been able to deal with this sort of resource curse in a better way. And one thing that we tried to do at the state level was create a permanent mineral trust fund, very similar to what was in Alaska and Wyoming, New Mexico. And that's not going to cure all these things, but it's going to help us build assets as a state. And when there's these boom times, we can put some of that revenue into a fund that will build over time, long after all the mining operations shut down, long after all the drilling is gone. We're going to have something to show for it, and we can reinvest that money back in. And structurally, what's unique about West Virginia that's different than Alabama and Mississippi is we have mineral ownership and land patterns in the state that are very different. A large portion of the private land in the state is owned by big out-of-state mostly land holding companies and coal companies, and that has been the history of West Virginia from the first time that George Washington came to Kanawha County and bought 22,000 acres. I mean, it's been a huge issue. Now out west, you're talking federal land. You know, it's very different, and there's different rules that come under that. But when you have sort of a more private system as we do, and then you get a domination of the political process and a lot of rent-seeking activity that wants to push policy in a way that's going to benefit those interests, it's very difficult to undo that. And we have very weak governance in West Virginia. We're always pushing for transparency, accountability. Yes, we want to invest in early childhood, but we want to know that the system's working. We want good evaluation of all of these programs, but we need to be more transparent and accountable to help ensure that there's not corruption in these things that can take place. So the weaker governance structure in the state is definitely something that's propelled it going forward. And I think if we can do things like some of these other countries and areas and use our natural resources to ensure that we're doubling down on higher education, that we're taking that money and building a more diverse economy that's going to be more stable and less susceptible to the boom and bust, we will have better outcomes, I think. But it's going to take a lot of willingness to do that, and it's going to take people in this room coming together and deciding that that's something that they want to see accomplished.
So we have made an effort today to connect population health to these larger social and economic factors. And the message, I think, that's come out from the audience based on the questions that I've seen is, yes, we get that it's a set of public policies and there is action needed from the ground up or from the top down in terms of action around these social and economic public policies. But we are still a health science center, are we not? And so we are still physicians, residents, public health practitioners, pharmacists, et cetera. And so it's a legitimate question that's being asked in other places, other countries. What do we do with our toolbox that we have as a health sciences center to address these social determinants of health, these public policy factors? And the question really for a lot of health sciences center folks centers around the treatment room. So I have a waiting room or a treatment room that's full of patients. Some of the factors that they share are income levels, education levels. I have been trained and equipped to work in this manner. What can I do about these factors? What do I need to learn or understand? Where do I fit into this discussion? And that's an important question. And I've seen some models where they are integrating new kinds of practices into physician training and physician practices. There are discussions about community-based public health, community-based research. But Dr. Woolf, can you talk a little bit about that question and where it fits, please?
Yeah, so I'm I'm a physician with a background in family medicine, and I also have training in public health, so I come at this from two different angles. When I'm talking to residents and medical students, there is that natural question, well, poverty's terrible, but that's not the field I went into. I'm not a teacher, I'm a doctor. So I have a pat answer for the question of what I as a physician can do about the social determinants of health. There's 3 levels of involvement, the first being the most important, which is the one-on-one relationship with the patient. So when seeing, I don't know, how many of you are clinicians? Some, okay. So for those of you who take care of patients, the responsibility is to address the social determinants of health as part of your understanding of your history and physical when you're seeing a patient, is to understand the kind of home environment that they live in and to provide support services to deal with those. And what Lauri's referring to is a new trend that we're seeing around the country in primary care and emergency departments and elsewhere, where patients who are being seen in those areas are also being helped with social services, unstable housing, housing vouchers, food stamps, other strategies to deal with these determinants of health as part of the prescription for dealing with their health issues and finding very dramatic improvements in health outcomes. So that's number one, is the one-on-one patient care. And that's essential. The second is by being active in their community. So physicians and other healthcare professionals can be part of social change in their community, efforts that are going on that Ted was referring to in many communities around the country, from the ground up at a grassroots effort to try to improve health outcomes. But when a physician comes in front of the school board or appears on local television and so forth and says, for the health of our community, we need to be doing more around graduation rates or the other particular determinants of health, that can be a big difference. And the third is through organized medicine, through movements that are happening at the state and national level, where advocacy by health professional groups and organizations give an opportunity for physicians and other healthcare professionals to tell Congress and tell their state leadership and so forth that change is needed. I want to go back to one of your earlier questions because I think it relates, it ties into what Ted was talking about. We're not talking about turning the United States into Sweden or Norway. We're never going to do that. But are there lessons that can be learned? So a study that was done by researchers at Yale University got a lot of attention from our panel when we did our report, looking at how much we spend on healthcare versus social spending. The countries in the world that have better health outcomes spend far more of their dollars on social programs than on healthcare. Let's turn that question domestically. Forget about Sweden and Finland and the other countries and just look at the United States. The states in the United States that have the best health outcomes are also spending more on their social programs than on healthcare. It's a complex issue because you don't know what's cause and effect, what's chicken and egg there, but it suggests, places like Minnesota and other places like that, that making these kinds of investments that Ted was talking about actually do more to improve health than pouring our dollars into healthcare after the diseases have already developed.
Mm-hmm.
Yeah, I
Did
was
you have a
gonna,
follow-up?
yeah, I was going to say also they make the state a more attractive place to live, work, raise a family, and start a business. Isn't that horrible? But I think, no, I was just going to follow up. I just agree with,
Okay. And this was a question from somebody in the room. And how many epidemiologists in here? How many people are studying epi? Okay. So when we first started looking at the connection between the social determinants of health and population health, there was a persistent question about the direction of influence. So what we're saying is that all of these factors influence population health. But then there was this kind of epi-like question about whether or not actually it wasn't the factors that were influencing health, but that health was worse for those people and therefore they tended to not be able to get jobs. I think that was like an ecological fallacy. I am a policy person, not an epi person. But I think this question kind of sums it up really well, this dilemma they first had when they were looking at all of these connections. And so maybe Dr. Woolf can help us with this one. And the question said, you mainly mentioned that little education would lead to low income and poor health, right? So we have that arrow going from low education, low graduation rates, and in the long run, we produce a population of adults that have poor health. So the arrow's going, I would say, from the left to the right. Is there any possibilities that the poor health is because of little knowledge of health and diseases before people go to college? As I think it's hard to reduce the gap between the rich and the poor, so there's that perpetual idea we will never get rid of the poor. Would more education of health and diseases in K through 12 be more helpful?
One is the value of increased education around health. And I think I mentioned that earlier. That is important, but I don't think it's going to have a transformative effect. I think most people who smoke cigarettes know that smoking is bad for your health. But yes, obviously health education, patient education is clearly important. But the other part of your question is what epidemiologists sometimes call reverse causality. And that's this question of whether the arrow is going to the left, from the left to the right, or whether that association that we're seeing is actually the reverse, which is that sick people are less likely to do well in school, or less likely to be employed, or less likely to be productive at work because of absenteeism and presenteeism. And of course, the answer is it's both. It's a bidirectional relationship. Both are going on. And it's very, very important to recognize that it's both, because it's actually a cyclical kind of relationship. Having said that, though, the body of the evidence shows that the left to right arrow is a much bigger arrow than the right to left arrow. Yes, there is reverse causality, and then those factors are important. But the main factor that's going on, and we know this from longitudinal studies that have followed people over time, is that adverse socioeconomic conditions cause a path going forward over the years, over the life course, that result in worse health outcomes. But it's certainly true that a child with asthma or ADHD is going to do worse on average in school, and that is going to translate potentially down the road in worse labor market outcomes and so forth than a healthy child. And that's why creating conditions that improve the health of our children and students is vitally important, and same for the workforce.
And I think from a public policy perspective, what we have found is that it is easier and less costly if you think that the arrow goes in the other direction. So we can fund health education, we can put those kinds of programs into place much easier than we can fund the big levers. What are the big levers that we need to move in order to address the gap, the social determinants of health? And so historically, when you look at the policy-making process, the budget appropriation process, it's much easier to fund those kinds of programs that focus on health education than it is to fund affordable housing or transportation or changes in NIOSH policies, so on and so forth. Does anybody have a comment they want to make in closing? I think I would really like to, Chris.
I would just add one thing to the previous question about what you all can do, and hopefully this leaves you feeling empowered. Like I was talking about before, with a lot of stuff, a lot of what really matters being played out at the regulatory level. Well, some of you may do this, I don't know, but you have the capacity. It is not beyond any of you to weigh in on the regulatory process, and they're actually required to listen to your input. And if you read a Federal Register notice, they will comment on individual commenters, and that the agency is actually required to take your views into account. And what I've seen working in DC is that there's a lot of policy that's made in the absence of real knowledge from people like you all on the ground who know what's happening or have good suggestions. So go to regulations.gov and submit a comment, and you will feel empowered, and you can see that the federal regulatory agency is responding to you in the Federal Register, and then you can put that on your refrigerator.
All right, okay. And on that note, I just want to tell you that next month we have the Commissioner of Health for West Virginia, Commissioner Tierney, so she'll be here on the first Friday in October. Thank you very much for your time, and we look forward to seeing you next month. Thanks.
So